Childhood onset end-stage renal disease carries a devastating toll. Pediatric patients face a 30-fold increased mortality rate compared to healthy peers, driven primarily by severe cardiovascular and infectious diseases. Prognosis has improved dramatically since the 1970s. Continuous advances in dialysis techniques and kidney transplantation have extended life expectancies that were once strictly limited. The NKF-KDOKI guidelines define CKD chronologically. A diagnosis requires structural or functional kidney abnormalities persisting for at least 3 months. Alternatively, diagnosis is triggered if the patient's glomerular filtration rate drops below 60 for that same 3-month period, even without other physical signs. This table maps the disease's clinical severity. Physicians categorize CKD into 5 distinct stages, directly corresponding to the declining efficiency of the glomerular filtration rate. To estimate GFR in a pediatric population, clinicians rely on a validated formula, 0.43 multiplied by the child's height in centimeters divided by serum creatinine levels. Establishing these strict chronological and functional thresholds is mandatory. Only after confirming the disease can a physician begin investigating the underlying etiology. Pediatric CKD is exceedingly rare. Current epidemiology shows approximately 18 cases per 1 million children. When investigating the origin of the failure, nephrologists apply a core diagnostic principle. The etiology bifurcates sharply based on whether the patient is under or over 5 years old. This table breaks down leading causes. Under age 5, congenital abnormalities like dysplastic kidneys dominate, presenting with growth failure and excessive thirst. In children over 5, the origin flips. Glomerular forms on the right, like focal segmental glomerulosclerosis, become the predominant drivers. These glomerular forms present with distinct clinical markers. Patients typically show edema, high blood pressure, blood in the urine, and heavy proteinuria. Age dictates the initial origin and physical presentation, but regardless of how damage begins, surviving kidney tissue responds in a way that forces all distinct etiologies into a single fatal mechanism. Renal injury presents a mechanistic paradox. Even if a physician successfully removes or treats the original disease, the kidney often continues to destroy itself. This ongoing destruction is driven by a final common pathway known as compensatory hyperfiltration. As nephrons die off from the initial insult, the surviving nephrons adapt to the loss of surrounding tissue. They undergo structural and functional hypertrophy to take on the lost workload. In the short term, this adaptation is highly effective. It temporarily masks the damage and preserves total renal function. But that extra work causes massive mechanical stress. The surviving nephrons are subjected to a sustained, elevated influx of glomerular blood flow, creating intense hydrostatic pressure against the capillary walls. This pressure forces a high volume of protein traffic to violently traverse the delicate capillary barriers. These rogue proteins exert a direct toxic effect on the tubular cells. They recruit monocytes and macrophages to the site, accelerating a rapid process of glomerular sclerosis and tubulo-interstitial fibrosis. Compensatory hyperfiltration locks the kidney into a vicious cycle. Under an ever-increasing excretory burden, the remaining nephrons are quite literally working themselves to death. As the surviving nephrons scar over and fail, the total GFR plummets. What began as localized renal failure now triggers a cascading systemic collapse. This table tracks the pathophysiology. A falling GFR causes loss of clearance. Nitrogenous waste accumulates in the blood, alongside dangerous potassium spikes, hyperkalemia. The kidneys also lose the ability to synthesize ammonia and reabsorb bicarbonate, plunging the patient into severe metabolic acidosis. The outward clinical manifestation of this internal poisoning is uremia. Patients develop worsening fatigue, muscle weakness, severe nausea, anorexia, and shattered sleep patterns. In this first phase of the cascade, the failure of the filtration engine effectively allows the body to poison its own blood supply. As renal tissue dies, the kidney's internal metabolic and endocrine systems collapse alongside its filtration capacity. Looking at the renal osteodystrophy data here, we see the onset of CKD mineral and bone disorder. The failing kidneys can no longer excrete phosphate or produce active vitamin D. This triggers secondary hyperparathyroidism, heavily disrupting calcium levels and bone density. When you combine that skeletal decay with metabolic acidosis and inadequate caloric intake, it drives severe growth retardation, a devastating complication entirely unique to the pediatric population. This is followed closely by a deep endocrine failure. The kidneys cease production of erythropoietin, shutting down red blood cell synthesis and causing normochromic normocytic anemia. As we see at the bottom of this table, that severe anemia intersects with uncontrolled hypertension and fluid overload, directly driving the development of cardiomyopathy and structural heart damage. Left unchecked, this pathology results in the total breakdown of skeletal development, cardiovascular stability, and red blood cell synthesis. To manage the disease, nephrologists deploy highly targeted pharmacological interventions. The goal is to break specific physiological links in this failure cascade and slow the rate of progression. To combat the mechanical stress of hyperfiltration, ACE inhibitors and angiotensin II receptor blockers are the first line of defense. They are deployed to deliberately reduce intraglomerular pressure and protect the surviving nephrons. Physicians then layer in thiazide or loop diuretics to control the specific spikes in hypertension caused by excessive salt and volume overload. To halt the mineral and bone disorder cascade, patients are placed on strictly low-phosphate diets, combined with active phosphate binders and synthetic vitamin D supplementation to artificially stabilize calcium levels. To address the endocrine failure driving anemia, patients receive erythropoiesis-stimulating agents, or ESAs. Provided their iron stores are adequate, these agents replace the missing hormonal signal and restart red blood cell production. Combating linear growth failure requires aggressive nutritional support, strictly mandating 100. Every prescription is aimed entirely at preserving the final surviving nephrons and sustaining the child's physical growth for as long as possible. Eventually, the hyperfiltration damage outpaces the pharmacology. The patient reaches end-stage renal disease, the absolute threshold where maximal medical management can no longer sustain basic physiological homeostasis. At this point, the indications for initiating dialysis become clear. The first is severe fluid overload that has become entirely resistant to diuretic therapy. A second indication is unique to pediatrics, when a child requires fluid restrictions so severe that it becomes mathematically impossible to provide the liquid nutrition required for their linear growth. Final indications include uncontrolled hyperkalemia, or subjective uremia that causes fatigue and nausea severe enough to actively disrupt the child's daily life and academic performance. When these thresholds are crossed, the patient must transition to renal replacement therapy. Through either peritoneal dialysis or hemodialysis, machines must artificially assume the excretory burden the kidneys can no longer bear. Dialysis is an effective bridge that preserves life, but the ultimate goal for every pediatric CKD patient remains successful kidney transplantation, the only intervention capable of fully reversing the systemic collapse and restoring a normal childhood.